Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and joining us today on Healthline for the very first time is oncologist Dr. Tharwat Ghattas with the Highland Clinic. Thanks for being here.
Thank you for having me. I really appreciate it.
Yeah, this is really exciting that your first Healthline. So we want to obviously get to know you as a provider here in the area. You're not really necessarily new to the area, but you're new to Healthline. So we definitely want to get to know you and why you decided to, first of all, I guess, become a doctor and then, specialize in oncology.
Well, thank you for having me today.
Yeah.
Well, I am not new to the area. I have been here in Shreveport since 2010. I matched here in 2010 in internal medicine at LSU. I finished my residency here in internal medicine, and actually I was working as a hospitalist at Highland for 9 years.
Oh, wow.
Yeah, I was a chief hospitalist for about 2 years, and I was a regional director managing value-based care for about 1 year. Originally, I did my medical school actually in Egypt. I was born and raised in Egypt, moved a lot in Egypt, but I finished my medical school in Cairo University in 2005. I mean, now I'm thinking about it, it's 20 years.
Wow, yeah, that's awesome.
It's about 20 years of medical experience now. Did a couple of years of nephrology, that's kidney disease in Egypt, and then I did my residency here in 2010, and then I decided to go back to fellowship and do hematology oncology and fellowship in 2021. After that, I was lucky enough to work with LSU Ochsner as assistant professor of hematology and oncology for 2 years. During these 2 years, I was seeing a lot of breast cancer, prostate cancer, and a lot of kidney cancer. My practice was between Monroe and Shreveport with Ochsner. I was spending a couple of days in Monroe, a couple of days here. So I was lucky enough to be able to serve those patients, and especially in Monroe area, which is a very underserved area.
Yeah.
I always wanted to do oncology. I actually applied in 2010 and 2012 to be an oncologist, and then there was some family commitment that I had to get and be a real doctor for a while before I come back to training. And that's how I ended up with oncology in 2021.
Nice.
So that's where I wanted.
Yeah. Okay. And then now you're with the Highland Clinic, and you have a practice there where you exclusively see, or do you do hematology and oncology there as well?
Yeah.
Okay.
Yeah. So I joined Highland Clinic actually last month. So the plan was to always join Highland Clinic. I did a couple of years with Ochsner to help them through the fellowship and all of that. But the plan was always to come back to Highland Clinic. I have 2 practices with Highland Clinic, one in Monroe and one here in Shreveport.
Nice.
In Monroe, I spent a couple of days there, and I spent a couple of days here in Shreveport. So I was so lucky to do that. I was able to do that. Especially
as you mentioned that Monroe you saw was an underserved community, so you're still able to make a difference in Monroe with your practice there. So, so what would you say makes your clinic or your practice different than others, and maybe do you have a different approach that you like to apply?
Well, can I talk about Monroe a little bit first?
Okay, sure. Go ahead.
So, Monroe is a very special area. That northeast Louisiana is a very underserved area. First of all, the incidence of cancer, the number of cancer per 100,000 patients in that area is about 550 per year. If you compare that to the incidence of cancer here in Shreveport, it's about 400.
Wow.
So you have about 150 more diagnoses per year per 100,000 patients. The other challenge is because it's an underserved area and a lot of subspecialties, so the patient actually end up with late diagnosis. I see a lot of late cancers, which is very unfortunate for the area there. So that was the whole point behind opening a clinic there, is to try to help get those patients early as I can, and see them and try to get them in and get them treated as soon as I can. Now, the question is, what will make it different than other clinics? You know, cancer diagnosis is very personal. It's a very scary diagnosis, and it's very personal in a lot of level. There's a lot of big system here in North Louisiana that take care of cancer patients, which is they do a great job. But in the same time, in our practice, is we treat the person as we try to make them as a very personal relationship. It's not a number anymore that you go through the system and you get in. Do you see an oncologist? With us, it is very personal relationship. Actually, most of my patient has my cell phone number that they can call me anytime.
I love that. Yeah, so you really do try to make that connection, because like you said, it's a scary diagnosis, and so you want to make sure that they're understanding the process and they're making the best decision for their care, right? And you know, you present all the things, but at the end of the day, they still get to make that decision.
Absolutely. I mean, the first visit is the most scary visit. They come in, they hear the word cancer, and they're really worried, and they think that everything is going to be terminal and all of that. So my most time I spend in the first visit, I spent a lot of time, about an hour with each patient in the first visit. I try to go through everything we have so far from diagnosis-wise, like X-rays and CAT scans and MRIs. We put everything in perspective, and then we explain everything to the patient, and explain everything on the plan, what we're gonna do and why we're doing it, and what's gonna be the next step. And they will have a chance to ask so many questions, as much as they can. And a lot of the times they call back and it's like, I have more questions. I was like, that's fine, let's just talk about it.
Yeah.
But that is really important, in a sense, is that it makes them comfortable when they come in, makes them feel that somebody is there that got their back.
Right.
And somebody that actually care about them as a person. They feel seen and heard, and also have somebody that they can always come back to.
I love that, yes. And those phone lines are open right now. If you do have a question for Dr. Ghattas, that number is 318-219-4569. It's right there on your screen. We are talking about, the main segment of what we'll be talking about is national cancer survivorship. But if you have any questions about cancer or oncology, he's the expert, so give us a call and we'll be waiting for your question. So, so continuing with the types of services that you provide at the Highland Clinic, you know, what are some of those things that you provide that maybe people don't think about when they think about cancer?
Well, I mean, we obviously provide the standard of care for cancer. That we are on the top notch on the research and top notch on what is up to date right now for the patient care. So we provide that. We also provide the options if we need to do clinical trials, and we have our connections with other facilities that provide clinical trials, and we're working on our clinic to provide clinical trials in the next few months. But I think, again, it's you're not a number anymore in the system. We take care of you as a person, as one of our family. The minute you come into the clinic, our staff will trained and know how to take care of you from the moment you get in to the moment you get out of the exam room.
So typically when someone is seeing you, do they already know that they have cancer, or are you kind of a part of the diagnosis process too?
It depends. So that's a very good question. So it depends on what area you're serving. So in Shreveport, it's usually by the time they come see me, they already have a diagnosis of cancer. I may add more workup, I may add more imaging. I may order a PET scan, I may order MRI of the brain. I may call the pathologist to see what kind it is exactly. But most of the time when they come to Shreveport office, they already have a diagnosis of cancer. In Monroe is a little bit different because in Monroe, I try to expedite the process, to see them sooner, to not delay their care. I try to get them earlier, and I do the diagnosis myself.
Gotcha.
So we actually, in Monroe, we hired a nurse specifically for navigating that. So once the primary care sent me the consult, hey, I have this mass or this tumor in the lung, I don't have everything yet. And I was like, okay, just send them over. Then we take over, we do the CAT scans, we do the biopsy, we do the MRIs. And because I'm a very unique position by being here in Shreveport for the last 15 years, and I also in Monroe, so if there is a delay in Monroe for the care, I can get them here in Shreveport and try expedite everything.
Nice.
And try to get them diagnosed faster because it's time of the essence here. Any delay will be detrimental for the patient, and we'll try to get them as soon as we can, and we'll try to get everything done as soon as we can. That's the different service we have in Monroe. Shreveport is a little bit different. By the time they come see me, they already have a diagnosis, and I know what we're going to do.
Okay, very interesting. Well, June is National Cancer Survivorship Month, and that's our main topic today. And so, tell us a little bit about what this month kind of means for you as a physician, especially in oncology.
Well, we talked about how scary is a cancer. And the moment a patient hears, a person or a patient hears the word of cancer, it's really scary, right? And that is because for years and years, we didn't have the treatment we have right now. Today, like it's a time in history, like it's a turning point for treatment of cancer, because we have so many options of treatment, so many advancements for treatment, from targeted therapy to immunotherapy. Most of the time, actually, we don't use chemotherapy anymore. We have some specific cancers that we use chemotherapy, but we use a lot of immunotherapy, we use a lot of targeted therapy. So this month for me means hope. And I want the patient to know, and I want the community knows that it is not like even 10 years ago. Now we have a much better cure rate. Even in the worst cancer that we had problem, tried to get the patient alive for a few months, now we have so much treatment for those so they can live longer, and it turns to be a chronic disease. We have about 18 million Americans that survive cancer and alive between us. You probably know somebody that beat cancer around you. That is the beauty of what we practice, the time we practice in right now. So I know this is a scary word, and I know it's really, really, really scary, but at the same time, there is hope. And we have a lot of patients that beat cancer. We have a lot of patients that cancer turned to be just hypertension or diabetes, that you come in and you get treatment every 6 weeks or every 3 weeks, and you just live your life. So that hope is there. Actually, my clinic, when you enter, the first word in your face is going to be choose hope.
I love that.
Because I think it's really, really important for our patient.
Yeah, for sure. And, cancer, like you said, it can be scary, but I think maybe that misconception is once you're diagnosed, you immediately have to start like chemotherapy. And there's always those horror stories with how horrible it is, on the body. But that's not necessarily the case. There's so many other treatments and advancements that you're using in your practice.
Right. There's so much advancement now. I mean, we're excited about I tell my friends all the time that if I don't keep myself updated for a couple of weeks, I'm outdated. Because it just, something come up all the time. Like there's new clinical trials, and I think of it a lot of the time as a time capsule. If I can get you to have a quality of life with some treatment for a few months or for a few years, and then by the time that cancer, God forbid, progressed and got worse, we have another 2 options that got approved. We have another option got approved. I'll give you an example for small cell lung cancer, for example. This is the worst cancer of of the lung. If you look about even 3 years ago or 2 years ago, we only had 3 years ago, we only had just chemotherapy. And it usually recurred really fast, and then the survival was few months. But now if you look at the small cell lung cancer, we have chemotherapy, we have immunotherapy, and we just got approval for an immunotherapy that is really going to change the landscape of treatment for small cell lung cancer. So yes, it is scary, but we have a lot of options, and it's going to be, this is really turning point into treatment. And I'm lucky to be oncologist during this time.
Yeah.
Really, I am.
Yeah, that's awesome. And like you said, you're helping give those patients hope every single day. So do you have I'm sure you have many patients that embody, the survivorship, the anthem of this month, of Cancer Survivorship Month, and if you want to share any of those.
Yeah, so I just seen a patient actually a couple of days ago. Renal kidney cancer everywhere. When she came in, she was really sick when she saw me the first time. That was about 6-8 months ago. We sat down, we had a plan, we went through the treatments. The treatment was mainly immunotherapy and targeted therapy. There's no chemotherapy. And kidney cancer was fatal 5 years ago, 6 years ago. We only had some immunotherapies that didn't work much. But she was a champion because she went through the targeted therapy. Was a little bit difficult. We worked through all the kinks, all the side effects, and she always was very hopeful, very determined to work on with me to get her through the finish line. And we just got a CAT scan last week, and there's no evidence of cancer at all. That's in her
awesome.
body. So you go from stage 4, there's no evidence of cancer at all, and we call that complete response, meaning that we don't have any evidence of cancer right now. And I was sitting across from her, and she started crying, and I was like, I need to stop crying, otherwise I'm going to start crying myself. And
Yeah.
this is amazing. It's, this is more time with her kids. There's more time with her family. There's more time that they can use this time for memories. And and the treatment now is every 6 weeks, and she comes to just get 20 minutes of treatment and go home and live her life. I mean, so we turned it from a fatal terminal cancer to something we just live with. And that's what I want people to know is this is just because you have a cancer diagnosis doesn't mean that you're not going to be able to beat it. There's options for treatment, and we'll figure it out.
Yeah. Do you feel like it also depends on a patient's mindset too, and how willing they are to jump head first into the treatment?
Absolutely. I mean, I love when my patients come in and it's like, I'm gonna fight this. I'm gonna beat that. And I always tell them it's a war, and we have to take it one battle at a time.
Yeah.
Because it's so difficult to think about what is going to happen tomorrow. It's a lot of uncertainty and a lot of stress and anxiety associated with that. So what I tell my patient all the time is just like, here's what to expect from this. This is going to be a war. We're going to have to take one battle at a time, one day at a time. I want you to have a clear communication with me, so because I don't want them to be through the treatment with a lot of side effect, and they want to just ignore all of that and don't have a quality of life.
Right.
I want them to have this clear communication with me so we can deal with the side effects so I can get them to the finish line.
Yeah, and you mentioned immunotherapy and then targeted therapy. Can you elaborate a little bit on targeted therapy and what that is?
This is one of the most amazing advancements happening. You know, it took us about 50 years to understand all the basic science. So back in the days, even 10, 15 years ago, we just knew this is a cancer cell. But with the basic science where we can see what is in the cancer surface that we can target. And so each cancer cell has a mind of its own. And that cancer cell, there is some mutation happened that pushed it to be a rogue cell. Normally, you have a mechanism that, I mean, we have about 3.5 trillion cells, and we keep copying these cells all the time. And when you start copying and pasting, if you copy and paste one or two cells, that's fine, you're gonna be perfect. But if you start copying and pasting, copying cells out of 3.5 trillion cells, then there's gonna be a mistake happen. And that mistake is what we try to target sometimes. So if there is a gene mutation that happened to the cell to become rogue cell, then we can target that gene to say, hey, shut up, I don't want you to work too much here, leave that cell alone, I don't want it to grow.
Right, okay.
And sometimes the cancer cell, on the surface of the cancer cell, you have a receptor that you can attach an antibody, that antibody can go in and kill the cell directly.
Interesting.
So there's a lot of different targets that we can see, and it depends on the cancer also. So cancer cell of the breast is different than of the lung. So there's these different targets that we can target.
Interesting. Well, yeah, thanks for that little, I guess, cancer lesson, if you will, you know, and, you know, what do you, see, going back to getting patients to the finish line, right? Is there a difference between beating the cancer versus just surviving? I guess surviving and thriving, you know?
So, I mean, there's two types of patients that we see. There's a patient that the stage is early stage. Those patients are stage 1 to 3. The goal here is to beat it.
Yeah.
So we do everything to beat it. We're much more aggressive in the situation to get the right treatment on the right time and try to get them to that finish line, and take some time to get them there. So that's first type of patients. There's the other type of patients that are stage 4, for example, and those patients, the goal is trying to beat it enough to become just a chronic disease that we can survive and thrive through the treatment. So we don't have the same amount of tools for stage 1 to 3 compared to stage 4.
Right.
And I always think as a care of cancer patient is like a triangle. So you have the patient on top of that triangle, of one of those angles. You know, every patient is different in a sense. Like if you have an 80 years old patient with advanced or 88 years advanced stage, their goal of life is going to be different than a 41-year-old that have 2 kids that need to take care of that kid. So the patient has their own values, their own goals in life. And you also have the other part of that triangle is that angle of the cancer itself. The cancer cell itself has its own mind. In a sense, it has a driver that drives that cancer to go crazy, that cancer cell. So, and it evolves over time. So my job is to understand how this cancer cell, what is the driver in that cancer cell, and how it's evolving, so I can target it, I can use immunotherapy, I can treat it. So that's part of the cancer cell. And then the other part of me, which I am the oncologist, and in that part I am the oncologist, I have the knowledge and I have how to take care of those patients. So the whole cancer care is between these 3 components and working together, try to figure it out.
Makes sense. Okay. And with, let's say, I'm sure you have many, like we said, patient testimonials of them surviving or beating the cancer, but sometimes, unfortunately, that cancer can come back. So what is typically your goal once someone beats the cancer? How often do you follow up with them, and what's your strategy afterward?
This is really a good question. So most of the patients that beat cancer, we have a strict guidelines on how to follow them. And so, for example, if the patient has had breast cancer, we did the treatment, we did the surgery, we did the radiation, then depending on the stage, we either see them every 3 months or every 6 months. And when we see them, we examine them, and if we see something that is abnormal, then we dig more into that, try to figure out what is happening. So every cancer has a strict follow-up protocol for 2 years, 5 years, 15 years. We have that in our clinic, and that's really important, and it's a really good question. The other part about the survivorship is, as we said a minute ago, if it's a stage 1 to 3, we really try to be as aggressive as we can, because the goal here is to cure. And sometimes you have a long-term side effects from the treatment. And part of my job as an oncologist is to understand what are these side effects expected, and how to treat it, and how to let the patient, you beat it cancer now, but you also need to have a good quality of life with the leftover side effects. And that takes experience, and it takes a lot of explanation and a lot of understanding, so the patient doesn't feel so disappointed if something is left over as side effect, especially for young patients.
Well, we do have our first caller. Jim, are you still on the line, and what is your question for Dr. Ghattas?
Yes, I was just wondering, for prevention or yearly exams, I guess the general public, we all know about doing colonoscopies, or for men, the PSA, for ladies, for doing the breast test. But what other preventative tests should we be doing yearly? Or you just might speak on the term of prevention, or discuss prevention.
Those
are the only 3 I know of for the humans. Thank you.
James, that's a very good question. We were about to jump on that question in a second. So the best way is not to prevent is, so there is a lot of risk factors that can cause cancer. So actually about 45% of cases of cancer are preventable. So if you look at the causes of cancer, you see smoking. 1 in 5 patients with cancer are related to smoking. Obesity also can cause cancer, it's about 12%. Sedentary lifestyle is about 8%. Infections is about another 8%. So infection like hepatitis C, hepatitis B.
Oh, infection,
HIV, or human papillomavirus like HPV. That's why we have the vaccine for it. So the best way is to try to avoid these risk factors. A healthy lifestyle, normal weight, exercise, no smoking, alcohol also, minimum amount of alcohol. These are the main risk factors for cancer. I mean, if you avoid and try to control that, that's about 40% of cancer cases. So you automatically decreased your risk by about 45% by just avoiding these risk factors. But to your question, Jim, we have a screening, so if you have to see me, then I want to see you in an early stage. So the screenings we have lung cancer screening. So if you're a smoker more than 10 years and you're 50 years old, then low-dose CT scan is very helpful. You do it once a year, very quick test, and then we diagnose them in a very early stage.
Great.
You don't even need treatment after that. For cervical cancer, you do pap smear for women. For prostate cancer, especially if you have family history of prostate cancer, PSA at age of 40. For women with mammograms are really important. Some start at 40, some start at 45. It depends on the risk factor. And obviously colon cancer is one of the biggest cancers that we can prevent by just doing your colonoscopy. If you have a family history, we sometimes suggest to start at 45, but otherwise at the age of 50.
Great. And we have about, unfortunately, just 40 seconds left. So if somebody wanted to get in touch with you, where can they find you?
Well, I mean, we have GhattasOncology.com. That's my website. You can go to the website and just submit a form, or just call the number. I don't have the number with me now, but I will put it in the screen in a second.
And we'll have this on our website as well. And the great thing is that you'll be back next month. So, I wish that we could have had more time to talk with you, but you'll be back next month. Thanks for joining us.
Thank you.
Of course. Thanks for joining us. This will be on our website, ktbs.com/podcast.